So let's jump right in. We're going to talk about long COVID and particularly screening for some of the signs of neuroimmune and autonomic dysregulation. This is something that, let's just do a quick poll. How many of you are seeing long COVID patients at this point? So there should be a little pulse check there. You can hit a thumbs up if you're seeing these patients, thumbs down if you haven't seen them yet, but obviously you're curious about it, curious enough to be here. So we know that the numbers are on the rise. The numbers are kind of all across the board, anywhere from 10% to 70% of COVID survivors have persistent symptoms. So if you haven't seen them yet, you will see them. All right, cool. So it looks like the majority of you are seeing some of these patients already, and some of you are not seeing them yet, but you're here to learn. So kudos to you. You're going to be a little more prepared for when you do see these patients. All right, awesome. So my big disclaimer with this topic is that no one is actually an expert on this yet. It is going to take us years, maybe decades, to really kind of piece this out and understand it better. There isn't even really a consensus on the definition of, you'll hear it termed long COVID or post-acute COVID-19 syndrome. We don't even have clear definitions for what these things are. And I think that's part of why we're seeing such a vast range of numbers. Depending on what we call it or how we define it, it may be just 10% of people who end up with persistent symptoms versus 70 some, right? Especially if you define it as, just one persistent symptom lasting longer than 4 weeks. Yeah, 70 some or more of patients percent of patients are reporting some kind of symptoms. So we've got a long ways to go. Why am I teaching on the topic if admittedly nobody's an expert on it yet? Well, early reports indicated various phenotypes of long COVID patients. And it has been established that dysautonomia or postural orthostatic tachycardia syndrome and mast cell activation syndrome were some of those phenotypes. And I am a reluctant expert in these topics because I have these syndromes. I live with postural orthostatic tachycardia syndrome. And my case wasn't a virus-triggered case, but it still presents the same. And so I do see a lot of these patients because I had to learn about this for me so that I can manage it. So I do have many years of experience working with this similar patient population and this phenotype in particular. For me, as somebody who's been living with POTS for a long time now, when I heard that more patients are being diagnosed with POTS because of COVID, there was this weird, hopeful, optimistic, thing that happened where I was like, well, maybe if more people get diagnosed with this, we will have better awareness of it and better screening for it. People will get diagnosed sooner. Maybe we'll have more research on it and come up with better treatment options because it unfortunately has been neglected so far in healthcare and in research. So current theories on long COVID, why these persistent symptoms? Why do some people have the virus and the virus resolves, but they continue to have symptoms? There are a variety of ways that can look. But essentially, we have this perception of threat or danger, right? Our systems are always trying to determine, are we safe or is there a threat? And especially with a big enough threat or a chronic sense of threat, an ongoing sense of threat, we get an autonomic response. We get sympathetic activation. And so various things could start that process. And then a lot of other things can kind of feed into it, and it becomes a chronic cycle. So of course, anybody who has had COVID, whether it's a severe case or even a very mild case, there are clearly some immune factors that can feed into that. The virus itself, the inflammatory response or hyperinflammatory response that occurs, reactivation of previous viruses that the person has had, including Epstein-Barr. We're seeing antibodies, autoantibodies that perpetuate inflammation. They've found that some patients with long COVID have an antibody that targets the ACE2 enzyme, and that creates an excess amount of angiotensin II, causing a pro-inflammatory state due to an ACE1, ACE2 imbalance, and that can just keep the cycle going. Cardiorespiratory factors, change in blood gases. There are people who have enough lung damage that they are experiencing hypoxia and, of course, low oxygen levels, or even if the oxygen levels are doing okay, but they're compensating with a rapid breathing, they might be off-putting too much CO2. And so those respiratory factors can feed into this threat, danger, increased sympathetic activation. Emotional distress. Now, that's not going to be like the only thing at play here, because clearly other things are going on, but it is a factor that can signal enough threat, right? If somebody's really worried, really anxious, worried about how they're going to keep their job or support themselves with debilitating symptoms, then that emotional distress is a threat signal and can feed into perpetuating symptoms. And then, of course, those who did have an acute case of that was severe may have some organ damage, and the organ damage itself is known to increase sympathetic activity. And there are probably other factors that we'll figure out as we go along as well. But if we take a look at the neurophysiology of our threat or protective mechanisms, Stephen Porges has coined the term neuroception to describe that constant scanning of our environment that occurs on a subconscious level. You can consciously or rationally know that you're safe and that the virus has resolved and that you survived and you're okay. But if your system on a subconscious level continues to detect threat, and of course, we're living in, for the past couple of years, an environment that legitimately feels threatening, right? With a global pandemic and crisis. So if the subconscious mechanisms of protection continue to pick up on threat, it can continue to perpetuate sympathetic upregulation. And not even just that, any or all of our protective responses can become upregulated, sensitized, or dysfunctional. And that would be our autonomic responses, our fight, flight, freeze responses, our pain system. Of course, we know pain is an output that is designed to protect us, and that system can become sensitized. Our immune responses can become dysfunctional or upregulated. The body can go into a hypervigilant immune response or a hyperinflammatory response that is above and beyond what is necessary to clear out the virus itself. And then we even have some psychological responses that I like to call survival brain, right? And these are also designed to be protective. If you think of an acute crisis like hungry bear running at you, in that situation, a negativity bias and a very narrow focus, staying focused on that threat, being hypervigilant to any cue that might indicate distress, and even some catastrophization, projecting the worst case scenario in order to prepare yourself for threat, those things could be very adaptive short term. But when we see that these protective responses keep going and going and going and become more sensitive and more hypervigilant, then we really see an allostatic load and some dysfunction of these symptoms. And if you even take just survival brain alone, living in a constant state of a negativity bias, narrow focus, inability to see the big picture, feeling hypervigilant and catastrophizing, we know is not going to be a healthy way to live. Certainly decreases quality of life, and it can feed into further upregulation of other systems like the autonomic responses, the sympathetic input. So it is well documented that that cytokine storm that occurs with COVID-19 results from sympathetic activation. The sympathetic system and the immune system, there's a lot of crosstalk, and they work together to create some of these responses. Conversely, vagal stimulation, so parasympathetic activity, creates an anti-inflammatory response. And we can use that towards rehabilitation efforts. And of course, our conservative means of vagal stimulation can be as simple as teaching people how to do deep diaphragmatic breathing, right? Getting the diaphragmatic movement to stimulate vagal tone. So we do see a lot of neuroimmune crosstalk, which is why sometimes when you see the sympathetic upregulation, you also see immune, you also see some of these protective features kicking into high gear. Whether or not there was any organ damage. So for example, we know that the brain can be affected. Any organ with ACE2 receptors could be affected or damaged by COVID, but we're still seeing a lot of persistent symptoms, even with people who had a mild case where organ damage isn't at play. So if the brain does experience some damage, then of course you'd have neuroinflammation. But even if the brain perceives enough threat, might not be physical tissue threat, but if it's perceiving enough threat, it can go into an inflammatory state and create an inflammatory state throughout the body. So glial cells in the brain, microglia will create some pro-inflammatory cytokines and chemokines that have a widespread physiological effect and can affect many different systems of the body. So upregulation of these immune mechanisms, there's some terms that are being used to try, to describe this, and these have been around for a long time. These aren't new things. Mast cell activation syndrome has been implicated as one of those phenotypes that we see. It's essentially evidence of an immune system that is hypervigilant. It's not like a mast cell or mastocytosis where there are too many mast cells. It's that the mast cells become they degranulate too easily to things that aren't even threatening. So basically your body is getting inflammatory mediators and inflammatory response to things that aren't dangerous anymore. And this is very, very consistent with pain sensitization too, where pain response is generated to things that aren't necessarily a threat to tissues. Once you get that increased, heightened level of inflammatory mediators that just keep going and going and going, that can affect, again, any number of systems in the body. We see this with pediatric multisystem inflammatory syndrome, which doesn't occur often, thankfully, but I bring it up here just as an example of just how much the body can overshoot in its attempts to protect us. So this inflammatory syndrome occurs 4 to 6 weeks after an acute COVID-19 infection is what they're finding in otherwise healthy kids. And even though those acute cases of COVID in these kids is like a mild case, it doesn't even have to be a severe case, they're having an extreme inflammatory response that can even lead to death. And so that just tells you, like, if healthy kids, have an immune system that can overshoot that much that it causes coronary artery dilation, aneurysms, myocardial dysfunction, it's just an example, again, pretty rare. You probably won't see it, but our immune systems really can overshoot, and our systems can really try to protect beyond what is necessary and to the point where it is harmful. So some signs that you may see, much more likely to see these in the clinic, are signs of hyperactive immune responses, and then, of course, hyperactive protective responses as well, including pain. And so allodynia and hyperalgesia, oftentimes you'll find this upon palpation, just even a light touch that is a non-noxious stimuli it is creating a pain response. Or if you push a little deeper and you really do like a deep palpation that could be potentially a noxious stimuli, you're getting an exaggerated pain response. And so these would be evidence of a sensitized system, a system that's essentially trying too hard to protect, and it's using pain as its medium for how to get our attention and try to keep us safe. When it's more the immune system, you may observe dermographism. And so if you feel up to it, you could go ahead and try this out in the clinic, use a tongue depressor or something to draw, maybe write something on your patient's arm. For right now, if you don't have a tongue depressor and you're comfortable with it, use your fingernail and just, write yourself a little message on your arm. And then in about 5 minutes, go ahead and take a look at that, because if you don't have a hyperactive immune response, that level of just a gentle scratch to the skin isn't going to cause something like hives or welts or itchy immune type response. But in somebody whose immune system is a little hyperactive, a little too protective, what you'll see is something like this picture where it's very clear, raised red welts, and they may report that it feels itchy. So when we look at the long COVID phenotypes, there's the acute COVID status, where if the acute COVID presentation is severe or critical, their long COVID phenotype is more likely to look like organ damage and the result of organ damage, severe deconditioning, post-ICU syndrome. If the acute presentation of COVID is more mild to moderate, then we tend to see myalgic encephalitis or chronic fatigue syndrome. That would be the MECFS abbreviation. Sorry, I didn't spell that out. Or dysautonomia POTS, or this mast cell activation syndrome. And those are the cases that are particularly confounding because it doesn't make sense. It's a mild to moderate acute infection, and yet people are having kind of like this persistent response that doesn't even seem to have an explanation, because we're always looking, of course, for tissue damage or something structural or something that we can see, something that's tangible. And it makes sense if somebody has persistent symptoms if their organs were damaged. But if you can't, test keeps coming back as you can't find any sign of tissue damage, it tends to confound us. And historically, we don't do as well with those types of cases in the medical system. So I'm going to share with you some tools for screening for this kind of thing in your patients, in your patient population. And just know that when we talk about these different phenotypes, they are not mutually exclusive. People can present with organ damage, for example, and dysautonomia. They can start out with more of a organ damage presentation or severe deconditioning presentation, and then maybe that damage and deconditioning over time results in autonomic dysfunction, and so eventually they may present like dysautonomia POTS. The ones that I put here in blue do tend to have, they may have a component of orthostatic intolerance or autonomic dysfunction. So for example, mast cell activation syndrome tends to come with orthostatic issues, because if you're getting that degranulation and an immune response, you're getting some vasodilation that's inappropriate, and that vasodilation can create blood pooling and orthostatic issues. Dysautonomia and POTS is the only one that really that's part of the criteria, the diagnostic criteria. So we'll look at that. But definitely I would be screening for orthostatic and autonomic issues in all of your long COVID patients. So screening for orthostatic vitals, I want you to take a moment and just think about the last, I don't know, few times or maybe over the last few years that you've gone in for a medical visit. How often did anybody check your orthostatic vitals? Probably not a lot. It's something that we all know how to do. We're all trained in it. However, standard medical care, medical visits often, they're rushed. They don't have time for that, right? And so it wasn't surprising to me that a 2012 study found a lag time of 10 years between onset of symptoms and the diagnosis of POTS. For me, it was longer than that. I developed symptoms as a teen. I was losing vision because of presyncope 5-10 times a day. And I was just told, oh, you have low blood pressure. No big deal. So my symptoms actually had to get worse and worse and worse before it was finally recognized as a dysautonomia. I think that therapists can play a really critical role here because we do get more time with our patients. At least I hope you get more time with your patients and you could actually screen for orthostatic vitals. Sometimes I do it as part of a treatment session and bill for it because I bill for it as treatment because as I screen orthostatic vitals, I am also teaching them about how to manage orthostatic symptoms or teaching them about what's going on in their body. And I'll bill it as neuromotor re-education because it helps to know what's going on in your body and how to manage it. Dysautonomia is really an umbrella term for any dysfunction of the autonomic nervous system. There are a lot of different ways that it can present, but POTS is the most prevalent, especially in women of childbearing age. It's actually considered the #1 cause of disability in women of childbearing age because estrogen is a vasodilator. So women are more at risk. There are other forms. Orthostatic intolerance would be one. Somebody who's got just orthostatic hypotension that's very significant and symptomatic. Vasovagal syncope is another one. And you do tend to see dysautonomia as an end stage of many other forms of medical dysfunction. So Parkinson's disease, multiple sclerosis, spinal cord injury, all have in their more advanced stages, especially components of dysautonomia. It's estimated about 50% of cases are attributed to a viral trigger, but obviously there can be other causes. And the orthostatic intolerance is certainly a key feature, but it is not the only symptom. In fact, POTS has been called a misnomer because it's not just about the orthostatic tachycardia. The symptom burden is severe. If the autonomic system is consistently going into inappropriate sympathetic activation, then what you'll see is really dysfunction of any of the systems that the autonomic nervous system innervates. So some common symptoms would be extreme fatigue, malaise, nausea, shortness of breath, air hunger. It's often described as like a can't quite catch your breath or can't get enough air. Poor tolerance to activity, that's a key one to look for in this patient population. GI distress, temperature intolerance, presyncope or syncope. I put shortness of breath in there twice. Definitely a key feature. Headaches, light and sound sensitivity, distal paresthesias, blood pooling, feeling weak, and heightened pain responses as well. So if we go to this, you've all seen this chart of sympathetic, parasympathetic function. If you think about if that system isn't working well, any or all of these could go a little wonky, right? So if your system is registering threat, ongoing threat, it's overactivating the sympathetic nervous system. You may get shunting of blood to bigger muscles that would help you, to fight or flight. But in doing so, you'll see almost like Raynaud's type symptoms where distal extremities go white or go numb, or because the blood is being shunted towards the bigger muscles, right? And especially if that's happening all the time, these folks can end up with essentially distal neuropathy because those nerve endings aren't quite getting enough oxygenated blood regularly. Let's see. So screening for these features, some of it is you may notice the symptoms, right? If you're seeing somebody who like their temperature system isn't regulating well, they're getting nauseous, they're feeling faint, certainly watch for symptoms, but be aware of the diagnostic criteria for POTS, and also we can use our orthostatic vitals screening to really capture data that would indicate that the autonomic nervous system is dysfunctional or in distress. So diagnostic criteria for POTS, if someone is transitions to upright, so standing would be the measure. If they transition to standing and their heart rate increases by more than 30 beats per minute for adults, or more than 40 beats per minute in adolescents, because their heart rate is actually a little bit higher, they would have to have symptoms for at least 6 months in order to qualify for a diagnosis of POTS. You can have, if it's less than that, you could have signs of the orthostatic tachycardia. But if you've only had symptoms for like 2 months, they might not call it a syndrome yet. And then similarly, if they don't, there are people who have this going on, but they aren't very symptomatic. So if they're not very symptomatic, then they wouldn't necessarily qualify for we don't need to call it a syndrome, right? Absence of other reasons for tachycardia is a diagnostic criteria, is part of the diagnostic criteria. They do need to see a cardiologist who can rule out other causes of tachycardia. And something that's unique about these patients is an absence of orthostatic hypotension. So essentially, they transition to upright, blood starts pooling down in the legs with the effect of gravity, and the system isn't appropriately activating sympathetic vasoconstriction to help shunt the blood up to the head. It's usually delayed, and then sometimes it'll kind of overshoot. And so in those moments of not quite getting enough oxygenated blood to the cephalad region, they will experience acute orthostatic symptoms, dizziness, wooziness, feeling off. Over time, the heart learns how to compensate for that. It will figure out that it needs to start beating faster every time you get up in order to get the blood up to the upper region. So when we screen for this, we're going to do at least 5 to 10 minutes of supine first for these patients. And look at blood pressure and heart rate reading with them in supine. And then the 10-minute stand test, or sometimes called an active stand test, is where we skip sitting and have them go directly to standing. And if they can, if the symptoms don't become a fall risk, then you would measure blood pressure and heart rate at 1 minute, 3 minutes, 5 minutes, and 10 minutes. That's a long time to stand. What I'll share is that usually with these patients, I don't keep them standing for 10 minutes because they will test positive before that point. So once they do hit that, you're seeing the signs of tachycardia, Or if their symptoms are just too severe for them to stay standing, you end the test, right? Have them stand up right near the plinth or a chair so that they can sit right back down as needed. Because if you're screening for this, you know you're doing it because there's a known risk or there are some known symptoms of acute orthostatic issues. There are other tests that can be done if they can't tolerate a 10-minute stand test, but this would be kind of the first and foremost way of screening. A tilt table test can be used as well. It's where you get strapped into a table that tips you up gradually over 10 minutes. I can tell you that they don't have a lot of autonomic labs. You can't find that test at every hospital system. And there's often a wait list to get in more than a year to get one of those tests. So we do need to have some tools for how do we work with these folks. What do we do about this? We can't afford to have them just sitting around waiting for a diagnosis. If you're seeing orthostatic issues, you can go ahead and treat them as such. So I'm getting some questions here. Do you ever treat based just on symptoms? Yes, absolutely. So some of the situations where we might see that is if the client was not diagnosed with COVID, but they are showing long COVID symptoms. Yeah, I've seen a number of cases where people are having this response to the COVID vaccine, which of course is a positive thing, but on some level, the body can register this as a potential threat and respond with some of these symptoms. The studies that have been done on these patients often don't require a positive COVID test, but if they had symptoms that indicate that they had COVID, they'll admit them and start treating them as such. So yeah. Some other questions. People are asking about the body's not being able to utilize available oxygen. There are a couple issues with oxygen that are presenting in this patient population. One would be that lung damage where they're unable to get enough oxygen at the level of the lungs. And then there's the ME/CFS population that we have found some markers that the body is not utilizing the available oxygen well. So we'll talk about that a little bit more too. They would present with severe fatigue and inability to tolerate activity. And then somebody asked, how do you distinguish from post-ICU syndrome and dysautonomia POTS? That would be this, if you're screening for, and of course you could have both. Like I said, that they're not mutually exclusive. But if somebody's 10-minute stand test is positive, you would consider a diagnosis of dysautonomia and refer them for official diagnosis, since we can't diagnose that. We can screen for it, we can look for signs and refer appropriately. So even if they don't meet the diagnostic criteria for POTS, orthostatic vital signs are considered positive or abnormal if they stand up and their heart rate goes above 20, right? 20 to 30 would still be a tachycardia response, because normal would be more like 10, 15. They just might not meet the criteria for POTS. So maybe their case is not quite that severe, or it's presenting in a different way. If their systolic blood pressure decreases by 20 to 30 millimeters Hg, you're seeing an orthostatic hypotensive response. That is still an abnormal finding, indicates the autonomic nervous system is not functioning optimally. And some of these things, may have been present at least a little bit before. Some people trend towards orthostatic hypotension as their norm. What I'm seeing in this patient population is that if they had that going on before, it significantly increases after COVID. So maybe their orthostatic symptoms, perhaps it's their norm to get a little dizzy when they stand up too fast, but it gets drastically worse. And you'd consider that a change in their orthostatic vitals. So another thing that I see is systolic blood pressure that increases upon standing, and that would be an overshooting of the sympathetic nervous system, so that it is creating too much vasoconstriction, and you'll see blood pressure actually increase significantly upon standing, so more than 20 millimeters Hg. And again, all of this is in the context of symptoms. If they have an increase in dizziness, weakness, nausea, or these other persistent symptoms that we're seeing that indicate autonomic distress, even if they don't meet the criteria for POTS, dysautonomia should be considered for anyone with positive orthostatic vital signs, or even if they just have the symptoms, you could go ahead and treat them as such. And especially if you find abnormal orthostatic vitals, referral to cardiology would be appropriate. And cardiologists don't always treat this, because it is essentially their role is to rule out cardiac involvement or other causes of other reasons for the cardiac dysfunction. And then if it is determined that it's not really coming from the heart itself, it's more the autonomic control of the heart, you'd see a neurologist that specializes in the autonomic nervous system to help manage it. Getting some questions here. Somebody asked about intermittent chills post-COVID. That can be an autonomic response, because the autonomic nervous system controls temperature. It can also be kind of that reactivation of viral load that we see in this patient population. In which case you may even see that these folks will have a low level fever, fever chills that kind of can be triggered by most often exertion or some kind of trigger. These patients are reporting triggers that are not just physical. Increased cognitive activity can also bring on kind of almost like a relapse of some of the viral symptoms, or just further evidence of autonomic dysfunction. And somebody said, is there any indication that the heart rate response is muted by meds? Yeah, so of course, if you have somebody on a beta blocker or something that dampens heart rate, you may not see as much of this, but in that case, you would still see upon standing some kind of an increase. Their baseline is going to be lower because they're on something that dampens their heart rate response at baseline. So it's really what you're looking for is the change from resting or supine to standing. But that is actually one of the pharmaceutical treatments that they offer for people who have POTS is just a very, very low dose of a beta blocker that would get a little bit of a dampening of the heart rate. And it can be tricky to find one that gets that response without also bottoming out their blood pressure. So sometimes people will have to trial 4 or 5 different beta blockers before they find one that gets the dampening of the tachycardia without worsening some of their orthostatic symptoms. So somebody asked, what other medical conditions have you seen that are similar to long COVID? And that's where we see ME, CFS. The Institute of Medicine in 2015 tried to rename this systemic exertion intolerance syndrome, but I don't think that's really been put into use. So the diagnosis does require that the patient have a substantial reduction in their ability to engage in pre-illness levels of either work activities, education, social activities, personal activities. They'll demonstrate post-exertional malaise, which is a severe fatigue and maybe even kind of like a virus or ill feeling, maybe an increase in that temperature, sore throat, stomach ache. And the key feature with post-exertional malaise is not just the fatigue and the malaise, it's also that it is not relieved by rest, right? So they'll be provoked into this post-exertional malaise state where they're feeling very fatigued and very ill, without really having done much, which, is our cue that there's some kind of a mismatch happening. And then they go to rest and they can't quite rest it away. These are your folks who try to exercise and they're kind of out of commission for 3 days afterwards, right? Sleep tends to be unrefreshing. They don't wake up feeling better, right? And then two other criteria are at least one of the following: either a cognitive impairment, it's affecting their ability to concentrate or think straight, and we do see in this patient population some orthostatic responses. So again, you're going to want to screen for orthostatics. What do we do about this, about especially that orthostatic intolerance? Pacing is a big part of it. Pacing for the post-exertional malaise, pacing your upright activities. If they do have that orthostatic intolerance component, you really have to kind of pace out your upright activity and do some stuff that's sitting or reclined throughout the day to kind of give your body a chance to rest. But conservative treatment of those orthostatic components or the dysautonomia that comes with orthostatic issues, breathing, so diaphragmatic breathing and paced breathing, because when they go to upright, their brain is getting a message that they're not getting enough oxygen. And really, they're just not getting enough oxygen up here. They have enough oxygen and it's pooling down, oxygenated blood is pooling down below for a moment. But certainly when the brainstem, gets the message that there isn't enough oxygen up here, even if their systemic oxygen levels are fine, they're going to start breathing heavily, right? And so really getting them to pace their breathing, slow down their breathing. Even if you have somebody whose oxygen levels do decrease because they have had some organ damage, you'd still want to get them breathing diaphragmatically, because it's not going to help if they're breathing apically and fast up here. You want the oxygen to get all the way down to the bottom of the lungs where it has a better chance of perfusing. So diaphragmatic breathing, paced breathing, if they have POTS, really slowing down the breathing. Education, especially when your heart starts really pounding when you go upright and you feel like you can't breathe, that can make people really worry. And that emotional distress, unfortunately, only worsens the situation. So assurance that's the heart is okay, even though it's beating fast, for this dysautonomia POTS presentation. Management of acute orthostatic symptoms. So that's coaching people on, get up slowly, drink enough water, supplement with salt, increase your salt so that you retain some water and fluid. Compression stockings can be part of that management of acute symptoms. And symptom prevention, long-term management, would be learning what your triggers are and managing those triggers. So most of us have an intolerance to heat, because heat will vasodilate the blood vessels and contribute to more pooling. Then the heart has to beat faster. You get the idea. So a lot of these folks will complain of showers as being a trigger. And so if you're standing in a shower and the water is warm, you could see where that would lead to more of these issues. So learning what your triggers are, managing them, and then autonomic conditioning is where we can really make an impact with this this patient population. So what is autonomic conditioning? It is based off of the Levine protocol. And Dr. Levine has a lab in Texas. So I think sometimes you may hear it referred to as the Dallas POTS protocol. He studied POTS patients, and because there is this known orthostatic challenge, he decided to see what would happen if we did some conditioning, cardiovascular conditioning, strengthening, and removed that orthostatic challenge, or at least decreased it. So recumbent bike, swimming, rowing, these were modalities that were used to initially train people so that they could get a training effect. And he found that lo and behold, they can get a training effect. You can, especially if you decrease the orthostatic challenge, you've got enough wiggle room there to start training and get your heart to be able to pump more with each beat. And so over time, the tachycardia will decrease. He also found that symptoms decreased. His original protocol was 3 months. And I don't know anyone who's gotten through that protocol in 3 months. It is a slow process. So I shared here a modified POTS protocol. If you search for, it's the Children's Hospital, I believe, of Pittsburgh, who shared this publicly online. So the CHOP POTS protocol, if you search for that, it'll pop up. They did a version that's 8 months long. But really, it will depend how fast they get through the protocol. It will depend on the patient and their symptoms. It is not a protocol designed to be pushed through no matter what. It must be symptom-based. Otherwise, what you're doing is just provoking more of that post-exertional malaise and extreme fatigue and symptom increase, and that does not work. This is not the kind of thing that you can no pain, no gain, or power your way through. And what I'm seeing with these long COVID patients is that many of them are trying to do that. They are trying to go back to their previous level of activity and push through, and it just doesn't work. So what I do with my patients is kind of go over this traffic light analogy of, if your symptoms are rapidly increasing, if they are persisting for days, if your response to activity is limiting your ability to function and do your ADLs, that is a red light signal from your body. We need to slow way down. Yellow light would be symptoms that increase 2 to 3 out of 10 on the board, the 11-point scale. If those symptoms don't last for more than a day, it is a short-lived symptom increase, well, that's yellow light. Proceed with caution. But green light, yes, they will have some symptoms, but they're minimal, and it resolves by the next day, and it resolves with rest, right? That would be a green light. You don't have to start these folks at the very, very beginning. For example, if somebody is tolerating walking for half an hour and they don't have these kinds of symptoms or post-exertional malaise, well then, yeah, they're already at the point where they can be upright and they're tolerating it, and you start them there. But what I see most often is that people are trying to do things like go for a walk because that's an easy form of exercise, right? Even their physicians are telling them, hey, you've got to recondition yourself after having COVID, just take it easy and go for a walk. But if walking makes your heart rate go up to 120, 130, and you're kind of already at your max and it's provoking symptoms, that's not going to be an appropriate training modality. So we start them with less of an orthostatic load, and then gradually, as they're tolerating more, then you work up to upright exercise. This has been applied in the post-acute COVID population. And I've got kind of a detailed protocol here. Some of these patients will need to just do breath work for a while, just try to calm the autonomic nervous system, improve ventilation, improve oxygen perfusion. When they're ready, when they can tolerate it, 2 sessions a week of essentially horizontal active range of motion, straight leg raises, bridges. They did 30 seconds of that active range of motion and horizontal, and then a rest break where they do the active deep diaphragmatic breathing. They need to be able to tolerate that well before you go to the next level, which would be a little bit more strengthening, more by way of duration, more by way of starting to introduce sitting positions. And they had a stop protocol, which would be, the way that they allowed this to be symptom-based, right? So if a patient had an increase in their symptoms by more than 3 out of 10, if they needed more than 5 minutes rest after doing some active range of motion or some easy exercise, that would be like, kind of red light, like, let's back off, right? We've got to slow way down if that's the response that you're getting. But if they're getting green light, then you could go ahead and proceed to next levels, ultimately getting them walking for short periods of time, 1-minute intervals, and then progressing eventually to the Levine protocol or a modified version of the Levine protocol. And so what they found with this autonomic conditioning was that this is just more of the protocol itself. Definitely get cardiac clearance if they haven't already had that ruled out. Some patients will need prehab 4 weeks of breathing to be able to tolerate starting to exercise. And during that time, you're also teaching pacing skills and using your other skill sets. Then what they did find with applying this in this patient population was that function improved. They were able to tolerate walking much better, and being upright and better. Their number of symptoms decreased and their fatigue severity greatly improved. So you can see improvements in this population, but I'm going to wrap up with this slide here and ask you guys to do the pulse check again. How many of you have seen these messages of standard rehabilitation may be detrimental in this patient population? Thumbs up if you've heard that. Thumbs down if you're going, what? Why would standard rehabilitation be detrimental? We're just trying to help, right? Has anybody heard that standard rehab can be detrimental in this patient population? I'm going to start explaining while you guys offer your thumbs up, thumbs down. So if people have significant fatigue and malaise after activity, physical or mental activity, if activity is triggering a recurring flare of viral type symptoms, if they're unable to maintain their previous levels of activity and they're having these severe symptoms that are really limiting their participation in everyday life, they can't sleep it off. They can't seem to rest it off. They're having cognitive symptoms, inability to concentrate. They've got the orthostatic issues going on. This would be a little bit more of that post-viral fatigue type of presentation. And if we don't work with them where they're at, then yes, a standard rehabilitation program can be harmful. So it's actually looking like more of you have not heard of this than have heard of this. So I'm glad you're here, and I'm glad you're hearing it from me. I do believe that when you do see these messages, please know that that's not the case for everyone. Some people you will be able to utilize kind of rehabilitation tools like graded exercise. And that's really what they've studied the most is in this patient population, people who have post-viral fatigue syndrome or ME, CFS. If they are put on a graded exercise program that is not symptom-based, if they're just told push through it, they get worse. And many of them will not continue with treatment, not come back for more sessions with you. If you can adjust that standard rehabilitation to account for where they're at and what their symptoms are, and do the red light, yellow light, green light, base their their progression through the protocol or activity, graded activity, base it off of their symptoms, slow down as needed, offer them more horizontal strengthening or activity than more upright. If you can make those adjustments, more of them will be able to progress. But some who really present with an ME or post-viral fatigue syndrome type presentation will really just need to primarily work with pacing and allow their body to rest before they can hopefully progress to more activity over time, slowly. So I'm going to go ahead and answer any remaining questions here. Somebody asked about RPEs. I use a 0 to 10 scale. I find that to be easier. I don't use heart rate as a indication of exertion, because of course we know with this population heart rate might be off. It may not be an accurate indicator of how hard they're working. What do you suggest when anxiety is a contributing factor to limited progression? I would say expect that anxiety will be a comorbid condition with this. And absolutely, they should have a mental health team that they're working with as well. But the good news there is, you know, some of the treatments that we're using, like the deep diaphragmatic breathing, also help with anxiety. There are common pathways, right? If we're getting some vagal stimulation or parasympathetic input, then that should help with anxiety as well. But yeah, expect that anxiety will be part of it, and hopefully they have other team members who are focusing more on treatment of that. So even I ask them, you know, what are you working on with your mental health therapist, and what strategies have you come up with for the anxiety, and let them teach me, you know, what works best for them. And then, okay, well, let's go ahead and utilize that as needed. Take breaks to use those strategies, whether it's deep breathing or something else that they've learned that works for them. And essentially treat it as active rest before we go ahead and try again with some activity if that's appropriate. Yeah, so other things that I'm seeing, some of you are sharing that you have some of these symptoms, and that is something that we are finding in the literature, that a good number of healthcare professionals are struggling with these issues. And I can so relate to that, because I'm also both treating these patients and trying to manage my own. It's not an easy task. So definitely try to pace yourself and take care of yourself as you're working with these folks. Somebody pointed out, because of that slow progression that you have to do, does insurance cover visits? Yes, in my experience they do, but you have to document the activity intolerance. Do they recognize this diagnosis? There are ICD-10 codes for history of COVID and post-acute COVID symptoms. And so far I am finding that insurance is covering. I think hopefully we see that trend, that it is getting covered, because it's going to have a significant impact. Somebody asked about manual therapy. Anything that gets a parasympathetic response or calming response or allows people to recover better. So as long as that manual therapy is being received well and it's calming and soothing, yes, it can be helpful. If somebody is having a more of a sympathetic response to a treatment, then that may not be a useful treatment. They're already getting a lot of sympathetic activity, and they need some help with regulating and kind of bringing things down to where they can find homeostasis and recover. Okay. I think that's, oh, here we go. I've got another question. Um, can you give an example of therapeutic paced breathing? So in this slide where they used therapeutic paced breathing, it was a 4-second inhale and a 6-second exhale that they used. So because that is evidence-based, that's usually where I try to start people. And I start them in supine and get them used to breathing that way. So it's a slow breath, 10 seconds for that breath cycle. So it's fairly slow. And a longer exhale, because that longer exhale is going to get more parasympathetic activity. The inhale phase is associated with the sympathetic, exhale is parasympathetic. So by lengthening out the exhale, we get a little bit more of a recovery or parasympathetic dominance. I have people start in supine, and then as they're able to tolerate more upright, get them sitting and doing that type of paced breathing. Eventually get them to kind of keep their breath kind of slow and reasonably paced, even with upright activity. Because in real life, when they're going to need it the most is when they, for example, stand up or go upstairs and their heart rate is real fast, they're breathing really fast. Being able to slow that down and kind of recover from that orthostatic challenge is going to be useful. But you could think of it as, I usually give people, initially at least 5 minutes of a breathing practice. If they're up for it, closer to 15 or 20 minutes of a breathing practice every day. And really kind of build up that ability to come down from the sympathetic states and really build up that parasympathetic dominance, and move towards homeostasis. And then especially as we start adding more activity in, they need to be able to use those breathing strategies to bring themselves back down and actively recover, right? All right. Good questions here, guys. I think I've covered most of them. So we're going to go ahead and wrap up. And I really do appreciate all of you being here. I hope you'll use these tools to both screen for these patients and initiate some treatment that's appropriate for them. If you do want to go in more depth with this, I do have a 2-hour webinar on this topic. And I even have a longer version than that. So we'll see if Summit wants to pick that up. But it's definitely I will say it's a learning experience. You will learn a lot about from working with these patients. And I thank you for being here to learn with me today.